Okay, hello everyone. Thank you so much for joining us again this week. We're gonna, as usual, just give it a minute before we get started. Hope you're having a wonderful Wednesday. All right. Welcome to this week's Wednesday webinar. We're gonna just give it a moment before we get started. All right. Well, good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on VWD and iron deficiency. My name is Alsan Murtha, and I'm the Manager of Strategic Communications here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will post to our speaker after the presentation. And if you're watching this webinar on one of our live streaming platforms, you can go ahead and comment your question and we'll pull it to post to our speaker after her presentation. This webinar is being recorded and will be available to the community beginning Friday, July 22nd. I am joined today by Dr. Bethany Samuelson, who may look familiar to some of you. She's done a lot of work with us here at NHF, and she has a great platform on Twitter, Dr. Period Hackers, that she co-hosts with another physician. Thank you for taking the time to join us today. I'll go ahead and turn it over to you to get started.
Great. Well, thanks for having me. I'm delighted to get to talk today about mostly about iron deficiency, but definitely about the overlap with von Willebrand disease and other bleeding disorders. So I don't have any conflicts of interest. I do have some grants, but none of that's going to influence the content today. So the objectives for today's talk, so we're going to talk about what is iron, what's its role in the body. We're going to talk about what is iron deficiency, the symptoms associated with iron deficiency, and then we're going to discuss the relationship between von Willebrand disease and other bleeding disorders and iron deficiency. And finally, we'll talk about management options for iron deficiency. So the first thing that I kind of want to address and get out of the way is, this is how I like to explain it to my patients. Iron deficiency and anemia, it's a Venn diagram, right? So you can have anemia without iron deficiency, you can have iron deficiency without anemia, and then you can have iron deficiency anemia. So most of what I'm going to talk about today is iron deficiency just with or without anemia, but it can be a little bit confusing when you hear different terms thrown around. So just to kind of create that perspective. So we'll briefly touch here about what anemia is, and then we'll focus more on iron deficiency for the rest. So anemia is low hemoglobin. So hemoglobin is that number on the complete blood count that really gives us information about what the red blood cell counts are doing, more or less. So hemoglobin, it's a molecule. It carries oxygen, which is important for life, and then carbon dioxide, which obviously we have to trade the oxygen out for. So there are about 300 million hemoglobin molecules per red blood cell. So there's a lot of it in our bodies. And essentially, the hemoglobin molecule has two main different types of components. One is globins, or just proteins, and then there's heme groups. And it's those heme groups that contain the iron, and it's the iron that binds the oxygen. So that's why iron is important for hemoglobin and red blood cells, and that's why when we get low on iron, we can get anemic. So iron is a mineral. It's probably the most common mineral deficiency that we see throughout the world. Total iron stores in an adult somewhere between 3.5 and 4 grams. So a decent amount of iron in our bodies when we're normal and healthy. Most of that, the vast majority of that, is in this hemoglobin molecule that I just talked about. So in the red cells, floating around our circulation, carrying oxygen to our organs and tissues. The next kind of biggest group, so myoglobin, which is muscle protein, and other tissues. We store some in the liver. We store some in macrophages, which are part of the immune system. And then in the bone marrow as well is where we keep some iron stores. Iron deficiency means low iron store. So it could mean that you have low hemoglobin because you don't have enough iron, or it could just mean that you're deficient in iron, your iron stores in these other tissues. So who is vulnerable to iron deficiency? So anybody can get iron deficiency, but there's certain populations where we expect to see it more commonly. So a big one is children. And a big part of that is kids need iron to be building these tissues. And so they have a big need for iron. And I don't know about you, if any of you have toddlers or no toddler, or we all were toddlers at one point, they're not great on eating really balanced diets with a lot of iron. So kids can get in trouble that way. But in adults, it's mostly menstruating individuals and pregnant people are vulnerable to iron deficiency due to blood loss with menstruation and after birth, and also just making iron donation to a fetus. Other folks who can be vulnerable to iron deficiency, so we see it not infrequently in folks who are frequent blood donors, which blood donation is great. We certainly encourage that. But if you do it too often, you can get into trouble with iron deficiency. People with inflammatory bowel disease or celiac disease, another group of patients who are vulnerable. If you've had bowel surgery, so that can be bariatric surgery, like a gastric bypass, or it could be if a section of intestine had to be removed for some other reason. Those folks are vulnerable to iron deficiency. Occasionally, folks with chronic nosebleeds, not typically in the sort of more general bleeding disorders community, but there are some specific, like a disease called HHT, where folks can get really bad nosebleeds and they can get iron deficiency from that. So that's kind of who we expect to see it in. Now, the underlying cause, we always say the top three causes are blood loss, blood loss, blood loss. Our bodies are very good at hanging on to iron and recycling iron that we take in. So it's pretty hard to get iron deficient unless you're having blood loss from somewhere. So most common cause, again, menstrual blood losses, particularly since they happen every single month. Losses due to pregnancy, losses from the GI tract is the next most common one. And so that can be from things like polyps or ulcers, but it can also be inflammation, a variety of other scenarios in which you can kind of have chronic oozing. The main issue with inadequate intake is kids. It's pretty rare for an adult to have iron deficiency just from inadequate intake, unless we're talking severe anorexia. Because our bodies are so good at hanging on iron, there's not a lot of dietary restrictions that will cause iron deficiency without some kind of blood loss. Inadequate absorption, like the example of celiac disease, where the body's ability to absorb iron in the gut is just totally shut off. There are occasional other rare causes. Sometimes in athletes, endurance athletes, there will be some breakdown of blood cells from the feet hitting the pavement, or in patients who have valve issues, there can be some damage to red blood cells in the circulation. And occasionally iron can be lost that way, but these are very rare causes. The vast majority of folks who have iron deficiency have blood loss from somewhere. And a big part of our goal is to figure out where the blood loss is coming from so we can fix it. Consequences of iron deficiency. So there are a lot. Iron deficiency can make people really miserable, which is a bummer because it's very common, but it's also good that it's easy to treat. So I think the most common symptoms I see, and I see a lot of iron deficiency in my clinic, fatigue and decreased exercise tolerance. We don't typically see people getting pale until they're also anemic, but iron deficiency without anemia can cause headaches, hair loss. Restless egg syndrome is one that's pretty easily reversed with iron treatment. A lot of my adult patients will complain of brain fog or just not feeling like they think as clearly. And in kids, there's actually studies that show decreased attention spans, poor scores on tests and things like that with iron deficiency. So it can impact us neurocognitively. Nail changes, like this example over here, are pretty rare, even with some pretty intense iron deficiency, but it's occasionally seen. The classic one that people always talk about is pica, which is wanting to eat non-food items. So I think, we think of toddlers wanting to eat dirt. That can be a sign of iron deficiency. Sometimes in a lot of my adult female patients will crave ice during pregnancy and other times when they're iron deficient. So that can be a sign. And then just overall decreased quality of life. So if you're having these symptoms and you're, still trying to function kind of normally throughout life, your quality of life is going to potentially be affected by all of these. So lots of potential symptoms and consequences. So talk briefly about the link between bleeding disorders and iron deficiency, specifically von Willebrand disease or bleeding disorders in general. So bleeding disorders by themselves should not cause iron deficiency. So it's not a part of the bleeding disorder itself to have low iron. But what happens is, again, the number one cause of iron deficiency is blood loss, and blood loss can be increased in bleeding disorder patients, particularly menstruating folks and pregnant folks. We don't typically expect joint bleeds or things like that to result in significant iron deficiency. But if there's blood loss to the external world through the GI tract or the uterus, then definitely we can see more blood loss in patients with bleeding disorders. Interestingly enough, there's some new data from a lab of a colleague of mine that actually suggests that iron deficiency could potentially worsen bleeding symptoms. And so they did this really interesting study where they looked at platelets, which are the cells in the blood that help us to form clots, and their ability to clot together to cover a surface. And they looked in a group of patients who were iron deficient, not necessarily anemic, before and after they got an iron infusion. And that's what this little diagram down here shows. So over on the left is how much the percentage of the surface that the platelets covered successfully before iron, and on the right you can see they covered more of that surface. And I will say that, in my clinical experience, I definitely have a lot of patients who develop easy bruising when they have iron deficiency, and it seems to get better when we correct the iron deficiency, patients with and without underlying bleeding disorders. So the main point of this is that I try to be a little extra aggressive with making sure that we're staying on top of iron deficiency and treating iron deficiency in patients with bleeding disorders. We want to make sure that we're not making the bleeding disorder worse. So next step is diagnosing iron deficiency. So first of all, who do we test for it in? So I check it in anyone who's menstruating at least once a year, if not more often. We should be checking people who have symptoms. So fatigue or decreased exercise tolerance. We need to think about iron deficiency, restless leg syndrome, and hair loss. Now, there are a million other reasons for hair loss that I, as a hematologist, have nothing to do with. But if a patient reports hair loss, I do like to check a ferritin just to see. I also check it around certain life events. So when planning pregnancy and after pregnancy, because iron is really important in pregnancy. And so I try to get people tanked up before they go into pregnancy, because it's always easier to treat iron deficiency when somebody's not pregnant than when they are. And then I usually check a ferritin 6 weeks postpartum in all of my freshly delivered patients to see if they need a little supplementation at that point as well. And then obviously anybody who has anemia is going to need to be checked for iron deficiency. So laboratory evaluation. So not the best test, but the most commonly ordered test is going to be a complete blood count. And this is where we look for that anemia, not specifically iron deficiency, but there are can be some hints towards iron deficiency or iron deficiency anemia on a complete blood count. So first of all, if the hemoglobin is low, the patient is anemic. Secondly, there's a metric called an MCV. And if you look at these test results when they come back from the lab, there are a lot of really not useful bits of information on CBCs, unfortunately, but the MCV can be helpful. It stands for mean corpuscular volume, which basically just means the size of red cells. And iron deficiency anemia cells tend to be small, which you can kind of see on this slide over here. They also tend to have a lot of white space in the middle when these should really be more completely kind of pink there. So that can be a hint for iron deficiency anemia. And then interestingly, platelet counts, those cells that help with clotting, are often increased in iron deficiency as well. So a lot of times this is the first and only test that somebody gets if they're just getting routine labs with their primary care doctor. But from my perspective, it only tells half the story. The bigger picture, because again, we can get iron deficiency without anemia, comes from the iron studies. And in my practice, the only lab that I use is ferritin, because that tells us about the total body iron stores. And I have some diagrams later on that can kind of help put the circulating iron versus iron stores in perspective. But other doctors order other things. So it's common to get a serum iron. That really just kind of tells you how much iron you've ingested recently. It's not really a metric of overall iron stores. the transferrin or the TIBC can be a measure of the body's ability to store store iron or transport iron, and then the saturation is just the serum iron over the ability to transport iron, which can sometimes be helpful. But again, these variables really have to do with a lot of things that don't accurately reflect iron stores. So my preferred metric is the ferritin. That's what I use in my clinic. And here, as promised, is the little diagram explaining that. And so all the way over here, you see somebody depicting iron replete. So somebody who has all of the circulating iron they need in their red blood cells, and they also have stored iron. And this is what our goal is. Over here, you see somebody who's actually developed anemia from iron deficiency. They don't have enough iron in their circulation. And in between, you can see that the body kind of starts taking from stores first, depletes the stores first, and then eventually we'll see the anemia. And here is that ferritin number that I mentioned to you. So my goal is usually to keep folks above 50. There's debate about what the most appropriate number is. 50 is my practice. We typically don't see iron deficiency anemia until it gets much lower than 50. But we do start to deplete the iron stores in between. And so that's the reason my goal is to keep folks fully replete. But as you can see down here, the changes on the CBC that I showed you a couple slides ago, we don't really start to see those until you get all the way into the iron deficiency anemia realm. So that's why I don't find that to be the whole story. And that's why I like to check a ferritin as well in somebody at risk for iron deficiency. The downside to ferritin, why some people don't like it, is that it can be falsely elevated due to infection or inflammation. And in my experience, the best way to avoid missing a diagnosis of iron deficiency due to that is really just to use a high enough threshold. And so that's why I use that 50 threshold. In general, iron deficient folks aren't able to make a ferritin over 50, even if they're inflamed. And there's also evidence that folks feel better when we treat them to a goal over 50. So that's my personal approach. Different physicians might have different approaches, depending if there's concern for underlying inflammation or not. But that's just how I approach it in my practice. So managing iron deficiency. So the big topic. So this is how I explain iron to my patients in clinic. So I think of iron as a bathtub. So hopefully you all have good plumbing in your house. You know, if you turn that faucet on as far as it will go, the maximum, it's still not going to fill the tub as long as the drain is unplugged, right? And that's kind of how iron works. So in this scenario, the faucet really just represents how the gut's ability to absorb iron, which is limited. No matter how much iron you put into your mouth, only a certain amount of it is going to get absorbed. So that's kind of the faucet here. And so we have to keep in mind that a huge part of iron deficiency management is reducing the blood loss. Or plugging that drain so the bathtub can fill up and we can have full stores of iron. So the thing that we always get asked about is increasing iron intake. In general, for somebody who's already iron deficient, this isn't going to cut it. There's only so much iron your gut can absorb. You know, if you have regular iron stores at baseline and you just want to make sure that you're, having an iron-rich diet, maybe to prevent things, that's fine. It's not going to get you out of a hole if you're in it. There's some sort of general principles, which is that iron that comes from meat products is better absorbed. About 30 to 70% of that is absorbed as compared to, unfortunately, iron that comes from vegetarian sources like greens or legumes or nuts. It's not as well absorbed. We don't really understand why. But here are some kind of examples of ways to get 1 to 2 milligrams of iron per serving or 2 or more. More of the iron is going to be absorbed from this chicken, pork, turkey, and tuna than from the raisins or the whole wheat bread. It's just how our guts work. But in general, if somebody is iron deficient, then we need to be looking for things other than dietary changes. And so the first line in most cases is going to be oral iron preparation. So this can come in pills, this can come in liquid form, kind of depending on what works best for you. I don't have one that I specifically recommend over another. When I prescribe it, I always prescribe something called ferrosulfate because that's available in pretty much any pharmacy. But there are over-the-counter preparations. If If you do want to take an over-the-counter preparation, there's nothing wrong with that. I just caution you that over-the-counter supplements are not regulated in any way. So there's nobody checking to make sure that it actually has that amount of iron in it. And there's nobody checking to make sure it doesn't have something else in it that you don't want to be taking. The exceptions to that are supplements which submit to voluntary testing by these three corporations down here. And so the ones that do, they'll have these seals on their packages, and that says that they have voluntarily submitted the supplement. Sorry, my internet might have broken up for a minute there. Hopefully we're still okay. Verified that it really does have the iron it says it does, and it doesn't have something else. So that can be helpful. The other thing about oral iron is that it can take a few months to really increase levels and work. It's not an overnight thing, so it can take a bit of time. And it can cause side effects like nausea and constipation are the most common ones. Some patients do fine with it. Some patients find it intolerable. You never really know what it's going to do until you try it. But it is kind of an easy, just do it at home kind of thing. And so that's a major draw to it. Again, there's near infinite options for formulations, but they're all going to be limited, excuse me, by the gut's ability to absorb. So we used to tell people to take 3 pills a day, and it turns out you don't absorb more taking 3 pills a day than you do taking 1 pill a day because just the body's limitations in absorption. So things that can be done to help increase the amount that's absorbed either from a supplement or from a meal. So you can combine iron with vitamin C. So either 1,000 milligram tablet or just with a glass of orange juice. Vitamin C helps with iron absorption from the gut. And again, that heme iron, so iron that comes from animal products, also improves absorption. So if you want to take your iron tablet with a steak and a glass of orange juice, that's probably going to be the most bang for your buck. Avoid taking iron supplements with tea or coffee. Those can impair the absorption, as can calcium, so including like milk or dairy, fiber, or antacids. So so kind of a high maintenance supplement, but sort of depending, you know, I have some patients who they need to take it with their evening meal because they, like me, love their coffee in the morning, and that's fine. It doesn't really matter what time of day you take it. Those are just some things that you can do to kind of get the maximum absorption if you're taking oral iron. A strategy that became very popular, kind of a big buzz back in 2017, was switching iron. I already mentioned we don't do it 3 times a day anymore. We do it once a day, was this idea of taking it every other day. And that came from this study here, which was a study of patients with iron deficiency without anemia. And they could take a dose either every day for 14 days, or they could take it every other day for 28 days. And then what they looked at was how much of the iron was absorbed. And one of the main things that drives how well we absorb iron is something called hepcidin, which is our body's way of preventing us from getting too much iron if we eat a lot of iron-rich foods. It increases. So the levels of hepcidin in our body increase when we ingest more iron. They decrease when we don't ingest iron. And the hepcidin itself decreases the amount of iron we absorb. And so they looked at hepcidin levels and iron absorption if it made more sense if people took it every other day. And essentially, yes, a higher percentage of each pill got absorbed when taking it every other day. That's what this diagram down here shows. So with the first 7 doses, this was the general amount that was absorbed in people who were taking it every day, slightly more absorbed when they took it every other day. And same with the second dose, 7 doses and all doses. But you can see there's a huge amount of overlap here. And there wasn't a big difference in how much things improved at the end of the iron course, whichever one was taken. And the people who took 14 days worth got their correction in 14 days instead of in a month. So I don't necessarily find that to be particularly advantageous in terms of trying to get people's iron up faster. It doesn't do it really faster. If you have symptoms with iron deficiency, with iron supplements, so it may help with the symptoms. So if constipation or nausea or something, it may make sense to take it every other day in that scenario. And again, these patients weren't anemic, and anemia does help us absorb iron better. So this may not be as true in patients who are anemic. It may not be as true in patients with baseline inflammation, where the hepcidin levels may be higher. So there's a lot of factors that could influence this. So in general, I prescribe iron every day. And then if somebody feels like they have some side effects and they want to try every other day, that's generally fine. So back again to this diagram, the alternative to oral iron is IV iron. And in this scenario, I think of IV iron as kind of like taking some buckets of water and dumping it into the tub. So you kind of bypass the limitations of the faucet or your gut's ability to absorb here. And you can increase your iron level much faster with IV iron. So when is IV iron indicated? So if oral iron is intolerable or ineffective, we go to IV iron. If we need a quick increase in iron or hemoglobin, so if I have a patient who comes in and they're pretty anemic from their iron deficiency, if I have a patient who's pregnant and getting close to delivery, if I'm in any scenario where we really can't afford to wait, the 2 to 3 months that it will take us to get the efficacy from oral iron, I think about IV iron. Also, in some cases where losses outstrip oral absorption. So in most cases, and we'll talk a lot in the coming slides about minimizing losses, but sometimes there's just scenarios where you really can't do a lot to minimize the losses. And so IV iron is effective there as well. We used to be very afraid of IV iron because there was concern about anaphylaxis or a dangerous allergic reaction. That's less common with modern preparations. They've made changes to iron over the years, so it's quite rare. It's less than 1 in 1,000, no matter what formulation you use. Infusion reactions are more common, where folks will have kind of like flu-like symptoms. I usually tell patients they should be gone within 24 to 48 hours. And if it's not gone in 24 to 48 hours, then you very well may have an actual flu. But the main advantage is that you can get really rapid relief. So it really restores the iron stores pretty much immediately. Have patients who swear they felt better the same day or the next day, which doesn't make a ton of sense physiologically because you still have to use the iron to make the things that your body needs, but I don't argue with success. So if people feel better, they feel better. Here are some of the formulations I mentioned. Which one you get depends on a lot of things. It depends on what a local infusion center has. It depends on what insurance will cover. A lot of times it depends on cost. And then the main difference from a medical standpoint is just the number of doses that are needed. So I think Venifer is probably the most commonly used one. It's the one the insurance companies prefer because they think it's cheaper. It does take usually 5 doses to get the same amount as some of these other preparations, though. So I'm not a huge fan of it for that reason, but it's perfectly effective. It just takes a few more doses. It does have the lowest rate of anaphylaxis, but the difference in those is so minimal that I don't think it's necessarily worth it to force somebody to have 5 infusions just because there's a slightly lower risk of a very rare outcome. Injectifer is another one that we see used. It can be done in 1 dose. Our institution, we do it in 2 doses. I don't totally know the reason for that, but its power is beyond my control. So it may depend 1 or 2 doses where you go. Injectifer can cause a low phosphate in the blood, which is typically not terribly problematic, but it is a unique side effect to this that we don't see with the others. I don't like to use it in patients who need repeated doses for this reason, because the risk of that goes up. So if I have a patient who needs iron every 3 or 6 months for some reason, Injectifer is not my favorite. Other than that, it's pretty okay. InFed is the one I use the most, and that's because it can be done in a single infusion and get the dose all at once, and people get to kind of go on with their day. It's also pretty cheap, but it can be very hard to get a hold of. So currently my center is the only one in the state that I'm aware of that can actually get InFed for whatever reason. It's been on back order for a long time. Ferraheme is another great option that can be done in 1 dose, and it's one that we used when we didn't have access to InFed for a while. It is more expensive though. So lots of reasons that you may wind up with one over the other of these, but they're all good. They will all get the iron stores up, and they're all well tolerated. So any of them is reasonable. But as I mentioned, the other component is we got to plug the hole in that bathtub, right? We got to reduce that blood loss, that iron loss, in order to really make traction on treating iron deficiency. So how do we lose iron? So every day we lose 0.5 to 1 milligram. That's all from our, up to 4 grams of iron in our body, which is pretty impressive. And that's just basically lost like in skin cells that slough off, maybe in the gut. But our bodies are very good at holding on to iron. In a normal menstrual cycle, a patient will lose about 1 milligram over the entire menstrual cycle. With heavy periods, which are more common in bleeding disorders, of course, it can be 5 times that much. And if you think about that adding up every 28 days over the course of a year, you can lose quite a lot of iron that way. Blood donations have about 200 to 250 milligrams in them, which is why you can only donate blood so often. One thing I do caution people against, a lot of times I'll have patients, they'll come in and they'll say, oh, I know my iron is fine because I donated blood last week and it was no problem. So when they do blood donations, they only measure your hematocrit or your hemoglobin. So they only look for anemia. They're not actually measuring your iron stores. So just because you are able to donate blood doesn't mean you have sufficient iron stores. So just keep that in mind. Other ways we lose blood, so GI losses, so in the gut, ulcers, gastritis, polyps, inflammatory bowel disease, anywhere you can ooze. The gut is outside of the uterus. The gut is really kind of the only place in the body that you can lose a significant amount of blood without it being frankly obvious. We don't, the other spaces in our body don't tolerate the volume of blood that has to be lost to get iron deficient or anemic. So the vast majority of times, if it's not menstrual bleeding, it's going to be a GI loss. Again, occasionally nosebleeds in unique scenarios. Rarely, if somebody really if they're having a significant amount of blood in their urine every single day for a long period of time, doesn't take much blood to make urine look red. So it's pretty rare that this happens. Or if the blood is being broken down in the vessels, then blood can be lost that way. But mostly we run into problems with periods, pregnancy, and GI bleeding. So let's take a few minutes to talk about menstrual losses, because that is what I talk about all day, and I couldn't resist. Menstrual losses are the most common cause of iron deficiency in adults. Heavy menstrual bleeding impacts 30% of menstruating individuals, but 74 to 92% of menstruating von Willebrand's patients. So that's really where the big link is between von Willebrand disease and iron deficiency. The other thing about menstrual losses is they're cyclic and recurrent. So they happen every month. It's not like one really bad nosebleed or a surgery where you had a bunch of blood loss at once and it doesn't happen again. It happens again and again and again. The good news is that there are many options for management. Just wanted to call attention to this photo on here. So this is by an author. Her name is Jen Lewis. I think she's out of Denver, and she does art with menstrual blood. So that may gross some of you out. I'm sorry if it does, but I just thought this art was really beautiful and really kind of revolutionary, calling attention to this in our society in a way that we don't talk about enough. So wanted to share that. So heavy menstrual bleeding is one type of what we call abnormal uterine bleeding. So any abnormal uterine bleeding can also lead to iron deficiency. So how does one know if they're having abnormal uterine bleeding? You know, menstruation happens every month, so there's some blood loss every month. So abnormal uterine bleeding is defined by bleeding between periods, which is more common in the teenage years and also later in life, approaching menopause. If cycles happen more frequently than every 24 days or less often than every 38 days, both of those can actually contribute to increased blood loss or iron deficiency with the every 24 days, obviously, because there's more blood loss because you're losing it more frequently. When periods get less frequent, so more than every 38 days apart, that's often because ovulation isn't normal. And so the signal for the uterus to bleed is when ovulation happens and there's these hormonal changes. But the uterine lining continues to build up until it gets that signal. So what will happen is somebody will only have a period every 40 days or irregularly, but there will be more blood loss because the uterine lining has built up more. So those are ways you can get abnormal uterine bleeding. Bleeding with sex, always abnormal. Postmenopausal bleeding, always abnormal. So the bleeding with sex, it's less likely to get iron deficient that way, but postmenopausal bleeding certainly can, and is certainly requires attention if it develops. So heavy menstrual bleeding is the most common way this happens. And so to be more specific, what does that mean? So there's a technical definition, which is more than 80 milliliters of blood loss per cycle, but obviously we don't send folks home and ask them to measure their blood loss. Interestingly, it's possible now with menstrual cups, but not practical for everybody. So signs of heavy menstrual bleeding. So changing a pad or tampon more often than every 2 hours, passing clots larger than a quarter, and periods lasting longer than 7 to 10 days, all more common in von Willebrand disease and bleeding disorder folks. Iron deficiency is in and of itself a potential sign of heavy menstrual bleeding. And so if any of these develop, then it's a good idea to talk to somebody about treating those heavy periods and getting them under control. This isn't a talk specifically about that, so I'll just touch briefly. There's a lot of good options. So tranexamic acid is a first-line therapy, whether or not somebody has a bleeding disorder, to reduce menstrual blood loss. It can reduce it by somewhere between 20 and 40%. Doesn't really help with any of the other symptoms of menses, and it doesn't prevent pregnancy. So it's a great drug, but a lot of folks will prefer going with hormonal therapies because they do have those other benefits of preventing unplanned pregnancy, which is super important, and also can maybe help with cramps and other things. So the IUD can cause almost half of patients to not have periods at all, which is really awesome if you're having blood loss from other things. If you have those nosebleeds, if you have GI bleeding, stopping the periods obviously doesn't stop the nosebleeds or the GI bleeding, but it can help you reduce the overall blood loss. So that can be great. The implant can also be effective. Any form of contraception. So the only FDA approved ones there's a couple of different kinds of pills that are FDA approved for reducing menstrual blood loss. But really any of them will probably do it. So the pills, the patch, or the ring, talk to your gynecologist about what you're most comfortable with. And often we'll recommend continuous use of these agents to prevent having periods at all. Now, sometimes there's breakthrough bleeding. So sometimes there needs to be a period planned every 3 months or so. But if you can stop yourself from losing that 1 to 5 milligrams of iron every cycle with these, that's a huge win in the war on iron deficiency. For folks who are done having children or know that they don't want children, there are procedural options, endometrial ablation or uterine artery embolization can help reduce blood loss. People can still get pregnant after those, but they shouldn't because it could be very dangerous. And then hysterectomy, of course, is the definitive way to stop periods. Unfortunately, many of my patients who know or don't know that they have von Willebrand disease have a personal or family history of hysterectomy in their 30s or 40s to deal with menstrual bleeding. I like to think that we've made progress in recognizing it and managing heavy menstrual bleeding better than we used to, but still is sometimes the best way to go for some patients. So what about other kinds of blood loss? So frequent or recurrent nosebleeds, again, not a common way to get iron deficient. The best thing here is supportive care with humidifiers, nasal saline or ointment just to keep the nose moist, treating allergies, because if you're sneezing and blowing your nose a lot, that can obviously make things worse. If you're having nosebleeds bad enough to cause iron deficiency, you really should see an ear, nose, and throat doctor and see if there's something that they can do with local treatment or something. I put tranexamic acid on here with question marks. Tranexamic acid isn't a great first-line treatment for bleeding, for nosebleeds, because it takes 30 minutes to work. And we don't want nosebleeds to be lasting 30 minutes. But I do occasionally have patients, if I have patients who have enough nose bleeding to make them anemic or iron deficient, then sometimes it makes sense to take it preventatively. Or I occasionally have patients who, every time they have a menstrual cycle, they'll have 3 nose bleeds that week. And so for them, it might make sense. But in general, it's going to be a supportive care, getting an ear, nose, and throat doctor involved. Outside of menstruation and pregnancy, the vast majority of cases we're not going to know where the iron loss is coming from. And it's important to keep in mind that iron deficiency is always abnormal. So if I have a patient that doesn't have a clear cause for their iron deficiency, they're not menstruating, they're not recently pregnant, they're not having a bunch of nosebleeds, then the first step is always to be seen by a GI doctor and look for sources of bleeding in the gut. And usually that starts with everybody's favorite, a colonoscopy, but also an endoscopy to look at the stomach as well, look for and treat sources of bleeding. Occasionally, if the iron deficiency is bad and persistent, we'll then move on to something called a small bowel capsule study, which it's the pill camera that we can take a look at more of the gut with. But always important to figure out where the blood loss is coming from and not just say, oh, you have a bleeding disorder, you're iron deficient because of that. You really need to find where the blood is going, where the iron is going. So what follow-up is required? So in my practice, in general, folks should always be monitored after correction to make sure they're in the normal range. People with IV iron, sometimes the ferritin will come back and flag as high and they get worried. That's okay. It's not going to stay that way. The frequency with which monitoring needs to happen is really going to depend on prevention of additional losses. So in my clinic, I have a clinic where I see mostly menstruating and pregnant individuals. I'm usually simultaneously giving the iron and trying to control the periods. And I usually check every 3 months. I'll check a ferritin every 3 months until I really feel like the periods are under control or until the iron deficient, until the ferritin has been stable for a long period of time. Some patients I have to check more often. Some patients I check less often. But in general, menstruating folks or people with a history of iron deficiency, I make sure to check at least once a year. That's something that can commonly be done with a primary care doctor. You don't necessarily need a hematologist to do that. But it's good to stay on top of these things. And then I also repeat if somebody's planning pregnancy or after pregnancy. And so just a plug, if you have a bleeding disorder and you think you might want to be pregnant, it's always a good idea to go in and talk to a hematologist beforehand about all the various implications for pregnancy and what you might want to do during the pregnancy to manage the bleeding disorder. And also because you can get your ferritin checked because iron pills cause a lot of the same symptoms pregnancy do, constipation and nausea. So always nice if you can get things tuned up before pregnancy. And that is all that I have now. I wanted to leave a lot of time for questions. So I will stop sharing my slides here because I think there was something else that needed to go up.
Yes, let me go ahead and share my screen. Awesome, that was fantastic. Thank you so much for sharing all of that. Before we get started with our Q&A, we do have a couple polls that we're going to throw up for you guys to participate in if you're streaming with us on Zoom. So if you can go ahead and answer those, that would be fantastic. And I have several questions for you. So if you do have any other additional questions, go ahead and throw them in the Q&A feature for us. But the first one came to us from LinkedIn, and that says, which of these iron compounds improve iron indexes in the body? Ferric citrate versus ferrous sulfate.
I just say there's not really a significant difference. I just say whatever a patient can tolerate. Like I said, I usually wind up prescribing ferrous sulfate because it's the one that I can get from the pharmacy. But if you find that the ferric citrate works better for you, that's fine too. It's not, there's not a significant difference.
Great, thank you. So if you're prescribing iron supplements, are these normally covered by insurance?
That's a good question. They're typically very cheap, whether or not they're covered by insurance, but I have never had an insurance come back to me and say that they refuse to pay, or have I had a patient come back and say the iron supplements were too expensive. So I think either it's covered by insurance or it's just pretty cheap on its own. And you can always get it, you know, if the prescription doesn't work for you for whatever reason, you can always get it over the counter. If that's cheaper, just make sure that it's been verified by one of those organizations.
Fantastic. So how can a patient advocate best for getting the appropriate testing done to properly identify an iron deficiency, especially if the patient is not being treated at an HTC?
Yeah, I mean, anybody can order a ferritin. You don't have to be a hematologist to order a ferritin. So, I think you can say specifically that you're concerned that you might have iron deficiency even without anemia, and you'd like to get checked for that. You can ask specifically for a ferritin, or, the doctor may have a specific panel that they like to order at their institution. But I think, just bring up the fact that iron deficiency can be symptomatic without anemia, and that you're worried about that and you'd like to get that checked. But it's a very cheap test. It's pretty easy to do. So I don't anticipate that it should be a big barrier.
Awesome, thank you. Okay, let's see. Do iron infusions need to be mixed like factor?
That is a good question. I don't know. They're always done in a pharmacy. So we have an infusion center where our pharmacists prepare it. It is a liquid. It's hung in an IV bag. I don't know if it comes in liquid form or if they mix it in a hood, but it's not something that you would need to be doing yourself anyway.
Great. How long does it take to administer an iron infusion, and what does the process look like?
It's a great question. So it depends on which infusion. So I think with Venifer, people are usually in and out within an hour. Infed may take 2 or 3 hours. It's a bigger dose. It has to be infused more slowly. And it really depends on the institution you go to. So usually you're going to get checked in by a nurse. You're going to get your vitals checked. They may need to verify some labs beforehand. They may need to draw some labs beforehand. Once all that's done, then they need to get the IV iron from the pharmacy, and then they can hang it, and they can hang it over anywhere between 15 minutes and 1 hour, depending on the preparation. Sometimes if it's your first dose, some places will do a test dose, meaning they'll infuse a little bit and then watch you for 15 to 30 minutes to make sure there's no reaction, and then they'll infuse the rest of it. Our institution used to do that. We don't do it anymore because anaphylaxis is so very rare. And typically you don't have to wait and be monitored for an extended period of time afterwards. If you're doing okay, most institutions or infusion centers, I think, will let you go right away. If you're getting infed, I usually tell patients to plan on it either taking a morning or an afternoon, just because there's a few steps and the infusion is lower. With Venifer, it's usually faster than that.
Thank you. So what is the biggest takeaway you want the audience to walk away with from your talk today?
Oh, that's a good question. I think I would say, just knowing that iron deficiency is common and that it can cause symptoms even if it doesn't cause anemia. And so it's worth checking for iron deficiency specifically.
Great, thank you. Can iron affect your mood and anxiety levels? And have any patients ever told you they noticed a difference in their mental health post-iron infusion?
That's a good question. I don't know of any specific links with anxiety. I think, if your baseline, it can have some neurocognitive effects. So maybe some trouble focusing. If you're having trouble focusing and you're tired, then, certainly that is not going to help any underlying mood challenges you may have. I definitely have a lot of patients tell me that they just feel lots better overall in general after their iron infusions. I don't think I've specifically had somebody say their anxiety is better. If somebody is so iron deficient to the point that they're anemic, that can cause the heart rate to go up, which may impact anxiety. But in most cases, folks aren't that anemic. So, I think that would be the exception rather than the rule. But, in general, folks tell me more energy, less hair loss, maybe better sleep. So I think there's not really a downside to it.
Awesome. So what could HCPs, especially non-hematologists, do better to identify and treat iron deficiencies in people with bleeding disorders?
Yeah, I think, checking a ferritin annually, certainly in anybody who's menstruating, anybody who's been pregnant, as part of that kind of comprehensive visit, whether or not it needs to be done in patients who aren't menstruating, I think is debatable. I think just being aware, looking out for symptoms of it and checking on those folks. I don't necessarily do it annually. For example, in patients with hemophilia without significant bleeding going on. But I think just kind of being aware of the fact that which folks are at risk, checking for them, and then maybe knowing where in the community a patient can get IV iron if they need it. It's really easy for me at my particular institution. I have privileges at the infusion center associated with my hospital, even though I work pretty much exclusively at the HTC, but not every HTC has that option. But maybe having, knowing a hematologist in the area that they can refer to get IV iron if needed, I think is another helpful thing.
Great. So why do so many people complain of a metallic taste?
In what context?
I don't know, actually. Let's see if they can elaborate a little bit more. I'm assuming if you take an iron supplement, there might be a metallic taste.
Yeah, it's not, that's not a specific complaint that I hear a lot in my clinic. More often I hear folks have nausea or constipation, or they just find that it's really hard to take the pill every day, and then we wind up switching to IV iron. But yeah, I don't know. It's a good question.
Yeah, they elaborated saying that it's with the IV iron.
Oh, interesting. Yeah, I have occasionally heard that. I don't know why. I don't really know what would cause that. There are definitely different medications that can cause different tastes.
I'm sorry, say it again.
Some medications is just as a side effect will cause different tastes. That's not a side effect that we understand super well in any drug, but I don't think I've ever had anybody tell me that it was a persistent thing.
Wonderful. And that's all that I have for you today.
Awesome.
That was great. Well, I'd like to thank you once more for taking the time to join us this afternoon. We appreciate your time and your expertise. This was an amazing presentation.
Oh, thank you. My pleasure.
Of course. I'd also like to thank each one of our viewers for joining us. Please note that this recorded webinar will be available on Friday, July 22nd at hemophilia.org under the events tab with all of our archived webinars. Also available in the events tab is our upcoming schedule for our weekly Wednesday webinar series. Thank you again for joining us this afternoon, and have a wonderful week.